Okay, allergic eye disease overview. Description. Allergic eye disease range from the very common and annoying, although non-sight-threatening conditions, seasonal and perennial allergic conjunctivitis, through to a rare bilateral sight-threatening conditions such as vernal keratoconjunctivitis (VKC) and atopic keratoconjunctivitis. It is often associated with other allergic features such as asthma, sinusitis, and allergic rhinitis, hay fever. The onset of allergic disease usually occurs in childhood, although a significant other group experience onset post-puberty. The hallmark of all these conditions is mast cell degranulations with the release of vasoactive substances, especially histamine causing itch and redness. Although the different conditions covered by allergic eye disease have a similar etiology, they are sufficiently different so that they can usually be clinically separated. Occasionally, one form will evolve over time into another form of allergic eye disease, typically childhood VKC into adult AKC. Seasonal and perennial allergic conjunctivitis. SAC and PAC lead to ocular surface itch and irritation and are typified by a velvety edematous conjunctivitis without scarring. Contact allergic conjunctivitis, also called acute allergic blepharal conjunctivitis. The most common form of contact allergic eye disease is drop allergy. The allergy is usually to either the active ingredient or some other part of the formulation, most commonly the preservative. It can be difficult to distinguish drop allergy from drop toxicity. However, drop allergy usually occurs soon after repeat challenge with a single drop of the agent, whereas toxicity typically builds up over time. Vernal keratoconjunctivitis. VKC is seen exclusively in children and young adults, most commonly in boys. It is frequently associated with a significant other atopic disease, such as asthma or asthma, and frequently exhibits seasonal exacerbation, especially in spring. There are two forms. The more common palpebral vernal typified by giant papillae on the superior tarsal conjunctiva, and the less common limbal vernal typified by a focal inflammation reactions at the limbus. Where, when severe, VKC has the potential to lead to significant corneal scarring with resultant long-term visual loss through the development of chronic non-healing corneal epithelial defect termed shield ulcer. Atopic keratoconjunctivitis (AKC). AKC is an ocular surface cicatrizing condition mostly exclusively seen in adults with marked atopic disease, usually including facial, periocular eczema. The typical features include marked tarsal subconjunctival scarring and corneal conjunctivalizations and scarring. Giant papillary conjunctivitis (GPC). GPC affects the superior tarsal conjunctiva and is most commonly seen with soft contact lens usage, although it can occur less frequently with rigid contact lenses. There appear to be mechanical as well as allergic components to the condition. It may lead to temporary or permanent contact lens intolerance. Symptoms. The hallmark symptom of ocular allergy is itch. Other symptoms include redness, periocular swelling, irritations, a slight foreign body sensation, and, if marked as in VKC and AKC, photophobia. These conditions are usually bilateral, although frequently the symptoms and signs are asymmetric, especially if the allergen is a pollen or other plant matter. The disease exhibits periods of exacerbations and remission which may be seasonal in nature. Signs. To varying degrees, all forms of ocular allergy demonstrate signs of chemosis, vascular injection, superficial punctate keratopathy (SPK), lid swelling, even ptosis with severe disease, and conjunctival papillae, usually most marked on the superior tarsal conjunctiva, pannus formation, corneal vascularization, corneal epithelial ulceration, and corneal scarring may be seen with more severe form of allergy such as VKC and AKC. Management. The degree of therapeutic intervention is highly depends on the severity of symptoms and the risk to the ocular surface. Advice and allergens avoidance. Cleaning around the eyes and the flushing of the inferior conjunctival fornix with lubricant drops can be useful in clearing allergens from the ocular surface during an acute attack. With a more marked disease, such as VKC and AKC, the early involvement of an allergist is important to ensure optimal control of the multiple allergic diseases often present in these patients. Drops may need to be altered or ceased with CAC, and contact lens removed during the early treatment phase for GPC. Therapeutic. Many different classes of topical medications are used to treat allergic eye disease, ranging from over-the-counter medications such as ocular lubricants, antihistamine, decongestants, and mast cell stabilizers, to the prescription medication non-steroidal anti-inflammatory agents, corticosteroid agents, and cyclosporine A. The level of the therapeutic intervention is matched to the severity of symptoms and risk to the ocular surface and is discussed under the entry for each specific condition. Occasionally, systemic treatment with short-term oral prednisolone is required for acute flare-ups of VKC and AKC.